Welcome dear students, welcome to my channel. Today we are going to discuss about the upper limb topics. So as the students are going to head examinations, they are in need of their upper limb topics and lower limb topics. So just for a time being, I'm just doing this upper limb topics. So the first one I have chosen is the flexor compartment of forearm. Why I have chosen this flexor compartment of forearm is because the arm is very easy topic to finish off and understand that one, but a little bit complicated is the flexor compartment of forearm, that is also called as anterior compartment of forearm. So the muscles which are present in the forearm at the anterior compartment, they are responsible for the flexion movement. That's why the region is called as flexor compartment of forearm. Is going to explore this flexor compartment of forearm. So the first one we are going to see, after removal of the skin flap, we can identify the superficial fascia that is lined by the fat. After separating that and cleaning the superficial fascia, then we can identify the deep fascia that is called as antebrachial fascia. This is the deep fascia of the forearm. So the same deep fascia which is also lining the posterior compartment of forearm as well. Now, in this picture, we can identify the antebrachial fascia. So this antebrachial fascia is a continuation of the brachial fascia of the arm, and lower part of this forearm we can identify at the anterior compartment and as well as the posterior compartment. We can identify the thickening of the deep fascia, which is called as flexor retinaculum at the anterior aspect of the forearm, lower aspect, or the distal aspect of the forearm at the wrist, and the extensor retinaculum, which is present at the posterior compartment of forearm at the distal aspect of it. So that is, they are the thickenings of the deep fascia. Okay, then moving to the next, the vessels which we can identify in the superficial strata are the radial artery branches and ulnar artery branches, even some of the vessels which are also coming from the brachial artery as well. So these are all the cutaneous vessels which we can identify in the superficial strata. And the veins which we can identify in this part are the one which is laterally, we can see the cephalic vein, and medially we can identify the basilic vein. And these two veins, they are going to join with each other by the help of median cubital vein. Then again, the cephalic vein, which is extending upwards and lateral to the biceps brachii, whereas the basilic vein, which is also ascending upwards and enters into the arm at the mid part of the arm, where exactly the coracobrachialis is getting inserted. There it is piercing the brachial fascia and enters into the forearm, and it is going to join with the pair of vena comitatus and forms the axillary vein at the axilla. So whereas the cephalic vein, which is running lateral to the biceps brachii, and is running upwards and enters to the deltopectoral groove, and it is piercing the clavipectoral fascia and drains the venous blood into the axillary vein. That is a brief course of the cephalic vein and the basilic vein. The medial cubital vein, which has clinical importance, that to draw the venous blood, it is an important site and it is a preferable site for drawing the venous blood. Okay, so that is about the three veins which we can identify in the superficial strata of the anterior compartment of forearm. So these veins exactly, they are present anterior to the cubital fossa. In front of the cubital fossa, we can identify these three veins joining with each other: basilic, cephalic, and here you can see the medial cubital vein. Then coming to the skin of the anterior forearm is supplied by fasciocutaneous perforators. The largest one is inferior cubital artery, which arises from the radial artery at the distal apex of the cubital fossa. So these are the fasciocutaneous perforators, means which are piercing the fascia and then coming outside and supplies to the skin. Then coming to the nerves, cutaneous innervation, it is by median cutaneous nerve of the forearm, which is supplying to the medial aspect of the forearm, and laterally we can identify lateral cutaneous nerve of the forearm. Then coming to the next, muscles. The muscles which we can identify after separating the deep fascia or antebrachial fascia, we can identify the anterior compartment contains the flexor muscles, which are responsible for the flexion of the wrist joint and flexion of the digits as well. So these are arranged in the two groups, superficial and the deep group. In some books, they have mentioned like three groups: superficial, intermediate, and the deep. So to avoid confusion, I am just explaining you in the two groups only: superficial and the deep group. Let us see that. So superficial and the deep groups, they are properly separated by the intermuscular septa. So intermuscular septa, it is also a modification of the deep fascia in order to separate all the skeletal muscles. Okay, all the muscles. In order to separate all those muscles, the deep fascia is going to undergo modification and forms this intermuscular septa. Then coming to the superficial group, in the superficial group we can identify five muscles: pronata teres. So these muscles I am explaining you from lateral to medial: pronata teres. Then medial to the pronata teres we can identify flexor carpi radialis longus. Medial to the flexor carpi radialis longus we can identify palmaris longus. Then medial to this palmaris longus, flexor digitorum superficialis, and most medially we can identify flexor carpi ulnaris muscle. Let us just have a look at these muscles, how they appears after separating of the deep fascia in the anterior aspect of the forearm. So here you can see the pronata teres. So this pronata teres, which is forming the medial boundary of the cubital fossa. Then medial to the pronata teres we can identify flexor carpi radialis longus. Then the slender muscle belly, long tendon, which is the palmaris longus. And here you can see the flexor digitorum superficialis. And here, most medially, we can identify flexor carpi ulnaris. So we are going to discuss all the muscles one by one. First one is the pronata teres. The origin is, it is having two heads. It is arising by the two heads. One is humeral head and ulnar head. So the humeral head, which is arising from the medial epicondyle of the humerus and medial supracondylar ridge. So here, from here, the humeral head is arising, whereas the ulnar head, which is coming from the medial margin of the coronoid process of the ulna. Here you can see that medial margin of the coronoid process of ulna, which is giving origin to the ulnar head of pronata teres. Then, going to the course of this, these two heads, they join and proceed downwards, forwards and laterally, and forming the medial boundary of cubital fossa and forms a flat tendon. That tendon which is reaching to the lateral surface of the radius. Lateral surface, it is also most convex part of the radius. So it is running towards the lateral surface of the radius. Approximately it is present here. Yes. If we just rotate it medially, we can identify the roughened surface which is present on the lateral surface of the radius. And here, to this lateral surface of the radius, shaft of the radius, the pronata teres is going to get inserted. Then coming to the nerve supply of it, the nerve supply, it is supplied by the median nerve. Usually between the two heads of the pronata teres, the median nerve which enters into the forearm from the arm. So in the arm, we can identify it is present medial to the brachial artery in the cubital fossa. Whereas if you see in the upper part of the arm region, which is present lateral to the brachial artery, then it is crossing the brachial artery and comes medial to the brachial artery. Then after that, it enters into the forearm by passing between the two heads of pronata teres. You can identify the two heads over here. Okay, humeral head and ulnar head. Then moving to the actions of it, it is a main pronator of the forearm and acts as a weak flexor of elbow joint. Can you see the movement over here? So this pronation movement is carried out by the pronata teres. Yeah. In the movement, if you just move your forearm pronation movement, it appears like this. This muscle, pronata teres, is pulling the radius towards medially so that the head will be fixing to the ulna, whereas the lower end of the radius, which is rotating, even the head also rotating on the ulna and runs towards medially in the pronation movement. Then coming to the next muscle is the flexor carpi radialis longus. So origin is from the medial epicondyle of humerus by a common flexor origin. Then it is of some fibers, they are also arising from the antebrachial fascia and adjacent fascial septa. Then here let us see the flexor carpi radialis longus. So flexor carpi radialis longus tendon, which is descending down, and lateral to the flexor carpi radialis longus, we can identify the radial artery which is present lateral to the flexor carpi radialis longus muscle, and this radial artery which is present between the brachioradialis laterally and flexor carpi radialis longus tendon medially. Between the two tendons, the radial artery is present. So where we can find the radial artery pulse. So in the close image, we can identify the radial artery over here. Then this tendon is nothing but flexor carpi radialis longus. This flexor carpi radialis longus is perforating the flexor retinaculum and enters into the hand region. So where it is going and where it is getting inserted is it enters into the hand region and then runs over the groove on the trapezium, and then from that trapezium it is running towards medially, and it is going to divide into two tendons, and the two tendons are reaching to the bases of the second and third metacarpals at the palmar aspect. Okay, so there it is going to get inserted. Then the nerve supply is supplied by the median nerve, like a pronator teres, and action is flexor of the wrist joint, and combined actions of the flexor carpi radialis and extensor carpi radialis longus and ribs produce abduction of the wrist joint. The next muscle is the palmaris longus. There is a very small belly on the long tendon. So from the medial epicondyle of the humerus, this palmaris longus is arising, and then the insertion is like a cord-like structure. It is tendon. It is going to join with it is going to fuse with the apex of palmar aponeurosis. Then nerve supply it is by the median nerve, and action is it flexes the wrist joint and makes the palmar aponeurosis tense. So here we can identify the palmaris longus tendon, which is present medial to the flexor carpi radialis longus muscle. Yeah, here you can see the movement of the palmaris longus, action of palmaris longus. Next one is flexor carpi ulnaris. This flexor carpi ulnaris is the most medial of the superficial flexors of the forearm, and the origin is it is also arising from the two heads. One is humeral head coming from the medial epicondyle of the humerus by common flexor origin. Here you can see that common flexor origin. Then the ulnar head coming from the medial margin of olecranon process. Here you can see the coronoid process, and then medial margin of the olecranon process by an aponeurosis from the upper 2/3 of the posterior border of ulna. Yeah, here we have just rotated it posteriorly and try to see the ulnar head. So ulnar head which is coming from the medial margin of olecranon process of ulna, and then upper 2/3 of the posterior border of ulna. Okay, this red color line which I am showing you the origin of the flexor carpi ulnaris ulnar head. Then insertion is it is going to insert first. It is reaching to the pisiform bone. Then from the pisiform bone it is reaching to the hamate bone. Then from the hamate bone it is reaching to the fifth metacarpal base of the fifth metacarpal. So the place of insertion, the fibrous part, they are going to form some ligaments. So one is between the pisiform bone and the hamate bone, pisohamate ligament. Then from the pisiform bone to the metacarpal, pisometacarpal ligament, and between the hamate bone and the metacarpal, we can identify another ligament called as metacarpohamate ligament. Metacarpohamate ligaments. So these are the ligaments which we can identify in the palm region. Now the nerve supply of this flexor carpi ulnaris is by ulnar nerve. Remember, ulnar nerve it is supplying the flexor carpi ulnaris and also the medial aspect of the flexor digitorum profundus muscle. Okay, that we are going to see in a short time. Now let us see the next muscle is the action. Before going to see the next muscle, let us see the action of it. Acting with the extensor carpi ulnaris, it adducts the wrist joint. Acting with the flexor carpi radialis longus, it flexes the wrist joint. Then flexor digitorum superficialis. So this flexor digitorum superficialis is the largest muscle of the superficial group of muscles in the front of the forearm. That is why some books they have mentioned it as intermediate group muscle. Okay, so let us see the origin of it. It is also arising from the two heads. One is humero-ulnar head from the medial epicondyle of the humerus, then sublime tubercle on the medial margin of the choronoid process of ulna, and medial collateral ligament. So these are the different parts which the flexor digitorum superficialis is arising. The next part of origin is the radial head. Radial head from the anterior oblique line of the radius extending from the radial tuberosity to the insertion of pronator teres. From this part also the radial aspect from the radial aspect the flexor digitorum superficialis is arising, means it is not only arising from the ulna, it is also arising from the radius. Then the insertion is the middle phalanges of the medial forefingers. Flexor digitorum superficialis is getting inserted to the middle phalanx of the medial forefingers, means second, that is index, third is middle, fourth is ring, and fifth is little. These four digits, four phalanges, which are giving insertion to flexor digitorum superficialis, the middle phalanx of second, third, fourth, and fifth. Whereas the muscle splits into two layers. One is superficial layer and the deep layer. So in the superficial layer, we can identify. Let me show you that. In the superficial layer, the two tendons which are running and enters into the hand are the middle finger and the ring finger. So this is how the superficial layer tendons are passing. And the deep layer tendons, they are index and the little finger tendons. They are running deep. Okay, let me show you another diagram to how they are getting inserted to the middle phalanx of the palm. So this is the image to remember how this superficial group and the deep group of flexor digitorum superficialis tendons are running. So in the superficial group, middle finger and the ring finger. In the deep group, index and the little finger. And passing beneath the flexor retinaculum. These four tendons are passing beneath the flexor retinaculum and enters into the hand, and then it is reaching to the middle phalanx of the medial four fingers. The nerve supplied is by median nerve, and actions are it produces flexion of middle phalanx at the proximal interphalangeal joint. Then deep group muscles are, there are three in number and consisting of flexor pollicis longus, then flexor digitorum profundus, and pronator quadratus. Flexor digitorum profundus is the bulkiest muscle of the forearm, and origin is upper 3/4 of the anterior and the medial surface of the shaft of ulna and adjacent medial half of interosseous membrane. Let me show you that. So one is upper 3/4 of anterior and medial surfaces of the shaft of ulna and from the interosseous membrane. Interosseous membrane also giving origin to the flexor digitorum profundus. You can see here. Other fibers, they are coming in the form of aponeurosis, aponeurotic fibers coming from upper 3/4 of the posterior border of ulna with the flexor extensor carpi ulnaris muscles. So here we have seen flexor carpi ulnaris, and then here you can see the extensor carpi ulnaris, and here you can see the flexor digitorum profundus muscle. Then coming to the insertion of it, the muscle forms the four tendons which enter the palm by passing deep to the flexor retinaculum within the carpal tunnel. So in this picture, you can identify from superficial to deep. We can identify superficial. We can identify two tendons of flexor digitorum superficialis. They are concerned with the middle finger and the ring finger. Then here you can see the lateral one is for middle finger, medial one is for ring finger, and in the deep group, the lateral one is for index finger, medial one is for little finger. Below these four tendons, you can identify four other tendons which are lying in the same plane. They are nothing but flexor digitorum profundus tendons. So the insertion is these flexor digitorum profundus tendons, they are piercing the flexor digitorum superficialis tendons at the proximal phalanx, and then they pierce and enters into the interval between the two tendons of flexor digitorum superficialis, and they are reaching to the palmar aspect distal phalanx. Okay, palmar aspect distal phalanx. Here you can identify this flexor digitorum profundus tendons. So the action, if we're going to see that the nerve supply is by medial half of the ulnar nerve and lateral half is supplied by anterior anterosseous nerve, intern it is a branch of median nerve. Then actions of the flexor digitorum profundus is it flexes distal interphalangeal joint, medial forefingers, and also it helps to flex the wrist joint. Then other muscle is flexor pollicis longus. This flexor pollicis longus lies lateral to the flexor digitorum profundus. Origin is from upper two-thirds of the anterior surface of the radius. Upper two-thirds of anterior two-thirds of the upper two-thirds of anterior surface of radius, which is giving origin to the flexor pollicis longus, and also from the interosseous membrane, these flexor pollicis longus fibers are rising. Then insertion is, it is enters into the anterior surface of the base of the distal phalanx of the thumb, and there it is going to get inserted. Nerve supplies by anterior anterosseous nerve, which in turn is a branch of median nerve, whereas the action is it flexes the distal phalanx of the thumb. Here you can identify first it flexes the distal phalanx of the thumb. Then after that it flexes the secondary movement is it flexes the proximal phalanx and the first metacarpal joint, and then it is flexing at the carpometacarpal joint. So here you can see the carpometacarpal, then metacarpophalangeal, then here you can see the interphalangeal joint. This is a movement which is done by flexor pollicis longus tendon. Then the pronator quadratus, it is a flat quadrilateral muscle which extends across the front of the distal part of the radius and ulna. So these are the fibers are running transversely. Origin is from oblique ridge of the lower 1/4 of the anterior surface of ulna, and insertion is to the lower 1/4 of anterior surface of the radius. From ulna to the radius, this transversely this pronator quadratus is running. So the nerve supply is by anterior anterosseous nerve, intern branch of median nerve. Then actions are pronator quadratus is the chief pronator of the forearm and is assisted by pronator teres only in the rapid and forceful pronation. And lastly, we are going to discuss about spaces of PARONA. Spaces of PARONA, it is a facial lined potential space deep to the long flexor tendons of the forearm, where the proximal part of the synovial sheath of the flexor tendons of the hand extended. Just below this, all the tendons, you can identify the spaces of PARONA. Then boundaries are in front it is related to the flexor digitorum superficialis, and behind it is related to the pronator quadratus. Here you can see that. And above, which is present above oblique origin of flexor digitorum superficialis. Applied aspects are accumulation of the pus from the infected synovial sheaths of flexor tendons may extend into the space of PARONA, means may extend behind the flexor digitorum superficialis of the profundus tendons. The pus is drained by incisions along the border of the forearm, which are not crossed by the motor nerves and act as intravenous lines. So that is about the flexor compartment of forearm. If you have any doubts, please contact me freely. Thank you.